Before I start all of my trainings, I always remind my audience that suicide is a very personal issue for all of us. Many of us are survivors and have lost a friend or family member, colleague, or client to suicide. And some of us are survivors of suicide attempts. So I want you all to, pay attention to how you feel after we're done today. If it's disturbing for you, please take a break and do something nice for yourselves tonight or over the next few days, because we don't spend enough time emphasizing the importance of self-care for caregivers. And we know that if we don't address that, then in our profession, we have a lot of burnout, and then we lose good folks like yourself who we need out in the field doing this important work. So we know suicide is a global public health issue. It actually kills more Americans than car crashes and more people across the world than natural disasters, war, and homicide combined. It kills more soldiers than combat, and about 20 deaths each day in the US are veterans. It's the #1 cause of death of teenage girls across the globe. And it kills more firefighters than fire and more police officers than crime. And we know now about how wide-ranging the impact is. We used to think that suicides impacted someone's family, immediate friends, but it's estimated now that about 135 individuals are impacted for every death. It affects someone's immediate family, their extended family, their community. If there's youth, it affects their school and their sports teams. And those effects can linger for years because of the stigma and shame that often follows. Now, we know a lot about our youth and young adults because the Centers for Disease Control does this survey every other year called the Youth Risk Behavior Survey. And what students themselves report back year after year is that about 8% will attempt suicide each year. So if you're in a school and you have, 30 kids in your class, 2 to 3 of those kids every year will attempt suicide. And it's usually 2 girls and 1 boy, because girls attempt twice as often as boys do. But boys actually die by suicide 4 times as often as girls. And there are a couple reasons for that. The first reason being that that boys have tended to choose a more lethal method when they make their attempts. They tend to choose a firearm or hanging, and girls tend to choose overdosing with medication. But the other thing is that there still is a larger stigma in our society for men and boys to ask for help. We see far more girls that are at risk who are, willing to talk to school counselors and be in therapy. These statistics make it the second leading cause of death among youth and young adults in our country. And we've actually seen a 150% rate increase over the last 5 or 6 years in suicide deaths of our youngest cohort in the 8 to 12 year age range. So it's not impossible to experience suicide in an elementary school. Now, there's a strong relationship between suicide and school violence. When the Secret Service, the Safe Schools Initiative study in 2002, it found that about 80% of school shooters had a documented history of suicidal thoughts or attempts prior to their attack. About a quarter of them said suicide was their motive, and that they just wanted to get revenge or make a name for themselves, which is why they did it in that manner. Yet only a third ever had an evaluation for mental health reasons, and just 17% were given a diagnosis. So a large group of people that have potential for some very damaging suicides that we're not finding. Now, as far as adults go, we lose in 2018, which is the last year we have statistics for, we lost about 46,000 adults to suicide. But for those 46,000 deaths, there were 1.5 million suicide attempts, and over 10 million American adults seriously consider it each year. So the people making attempts and thinking about suicide far outnumber those who will actually die. In fact, we have about 25 attempts for every single death. And it's very hard to figure out which ones of those folks who are thinking about it are going to go on to make an attempt and perhaps make a lethal attempt. And that's where you'll see that the Columbia tools can come in very handy. Now, you don't have to have a mental health issue to be at risk for suicide. We actually see increased risk for suicide in all medical conditions, especially conditions like cancer, where we've seen suicidal ideation at 18% independent of any depression they might also have. And similarly for back pain and brain injury and migraines and epilepsy and sleep disorder, lung disease, HIV, we see all those illnesses result in an increased risk for suicidal thoughts and suicide attempts. Now, while the greatest numbers of suicides happen in our cities, the highest rates of suicides are actually happening in the rural parts of America. And there are a couple reasons for that. The first is that in rural America, we tend to have populations spread out across a great distance, and they often have poor access to mental health care and medical care. In fact, a lot of our smaller hospitals that treat in rural communities are closing down. So sometimes it can be an hour drive just to get to a medical appointment. And when the economy is tough and families are struggling to make ends meet, they're not going to make that hour-long drive and spend the time and money that it takes to do that. But the other thing is that if you look at all of the demographic factors and compare them to rates of suicide, the one that most closely matches with rates of suicide are rates of gun ownership. And while this top map here is a look at rates of suicide by county in the US, the bottom map is a map of gun stores by county in the US. And you can see the areas where it's darkest purple and there are more gun shops are same areas where it's darkest blue and we have more suicides. And this set of data makes that point very dramatically. This is a look at the states on the highest end of gun ownership rates, where we have guns in half of the homes, and compares them to states on the lowest end of gun ownership rates, where guns are in just 1 out of 5 homes. New York, New Jersey, or Massachusetts, Rhode Island are all in that lower end group. And when we do that, we see that non-firearm suicides are roughly the same when the population is the same. About 8,100 men, about 8,800 men, a little bit of substitution there, 3,500 women, 3,600 women. But when you add the firearm suicides on top of that, you see about 4,000 additional for the states with low rates of ownership for the men, and 4 times as many, 16,000 additional suicides in the states with lots of guns. And in the women, it's almost 10 times, 300 compared to 3,000 additional suicides. So simply living in a community where there are high rates of ownership increases the likelihood that if you have an impulsive suicide attempt, you're going to have easier access to a firearm, which is lethal most of the time when it's used in an attempt. Now, there's also a connection, of course, between suicide and addiction. We see opiates in about 20% of all suicide deaths, and alcohol intoxication in about 1 out of every 4 suicide deaths. Alcohol intoxication is present in about 30 to 40% of attempts. And so if you have an alcohol misuse diagnosis, you're 10 times greater risk for suicide. If you are an injection drug user, you're about 14 times greater risk for suicide. And this is, new but not very surprising to us. It turns out a large portion of our opioid overdoses that are taking over the news in the last few years are actually suicides. And they don't always get marked on medical examiner reports as suicides because they don't always have enough information about motive to call it that. But when you look a little bit deeper, you do find that most of them are in fact suicide. And it makes sense when you think about it. What gets people involved in an opioid addiction is often a chronic medical issue where they get prescribed the opioid initially by their doctors and become addicted. Or, someone self-medicating a mental health issue. They have anxiety or depression, and they're using illegal drugs instead of getting a prescription for the drugs that might help them. And of course, there's a connection between suicide and our current COVID-19 crisis. Because of the loneliness and isolation, we're seeing more mental health issues become prevalent. And in fact, we see historically that when the economy turns downward, the suicide rate increases at a roughly equal pace. And, we know that, 35, 40% of Americans are feeling anxious or depressed as a result of COVID. And so in March and April, SAMHSA's distress helpline saw a 1,000% increase in call volume compared to last year. Our national crisis text line is getting 6,000 texts a week, which is twice their usual rate. And what they're seeing is that the majority of those calls are essential workers, are first responders, nurses, cashiers, domestic violence victims, grieving family members, and unemployed individuals. 80% of them say they feel lonely and isolated, and many of them feel uncertain about their financial future and the future health of themselves and their loved ones. So I don't need to remind you of this, but I'm sure you know suicide's biggest cause, which is a heritable treatable medical illness called depression, which is the result of changes in brain chemistry. But depression is actually now the #1 cause of global disability. At any one time, about 8% of the world suffers from depression. And it actually costs the world about $1 trillion a year and costs our nation about $300 billion a year. Yet compared to other illnesses, it's devastatingly underfunded. Based on the number of deaths alone, you would expect it to get much more research dollars than it actually gets. And traditionally, mental health has not gotten the research money that it really should be getting. And, it's a shame because it's a vital part of health and wellness for our economy, for employees and their families. Depression is actually the #1 cause of work-related absence. More people call out of work sick for depression than for any other medical reason. And that actually costs our workplaces $23 billion in sick days. And all of the costs of treating those folks could be offset by the gains that we would see in work productivity. So there are many EAPs now that we are working with to have them use the Columbia scales to identify suicide risk in employees of some very, very large Fortune 500 companies. Now, while most people with mental health issues aren't suicidal, 90% of those who die from suicide do have a mental illness at the time they die. And we think 60% of it's depression. But we know that mental illness in our nation is undertreated. About more than 50% of people who need treatment have no treatment or poor treatment, and about 7 out of 10 teens with depression don't get treatment. More than 8 out of every 10 adolescent and college student suicide deaths, the student never received any kind of consistent treatment. And we know that suicidal patients as a group can be very difficult to engage in treatment, right? One of the hallmark symptoms of depression is withdrawal and isolation. And so this study out of Cobb County, Georgia, looking at high school students actually showed that students in the high school there who made a suicide attempt were actually 2 to 3 times less likely to seek help from counselors or teachers when they were struggling during the year. And a lot of that has to do with stigma, in addition to the symptoms of depression. But we still have a big stigma when it comes to asking for help and getting treatment for mental health reasons. This is especially true in our first responders and military, where people are doing these very tough macho jobs. Actually, even if you're a woman doing these macho jobs, your risk is increased. It's because of the work that they're doing. So there are a few myths about suicide that I want to quickly review. The first being that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't stop someone who really wants to die. We know that this is false because multiple studies show that more than 90% of suicide attempt survivors, including people who make very lethal attempts and then survive them, don't go on to die by suicide later in life. In fact, most people are suicidal for a short amount of time, and it's one of those symptoms that comes and goes with levels of stress. So if you're helping someone in that time when they're feeling the most stressed that they've, ever felt, you may actually make a lifelong difference because they may get some treatment and they may never feel that bad ever again. Asking a depressed person about suicide may put the idea in their heads. We know that this is false. Talking about suicide does not make it any more likely that somebody's going to make an attempt. A lot of people, used to and do still worry that if I talk about suicide, shouldn't we be whispering it because, it might make somebody feel worse and they might, then make an attempt. But what we know is that that's absolutely not the case. Even when we've seen screening of an entire high school of kids, we don't see an increase in the negative feelings of any of those kids. In fact, open discussion about suicide is more likely to be seen as relief by those who are struggling through it. And of course, it's a bigger risk when we keep silent and don't ask these kinds of things. Someone making suicidal threats won't really do it. They're just looking for attention. We know that this is false. Even people who talk about suicide or express thoughts about wanting to die frequently, they are at risk for suicide. You can have a very low level wish to die that is your baseline, that just doesn't go away. This is common in folks, for example, with borderline personality disorders. And so even though they say it often, it's important that we take it seriously, because the time that, we brush it off and say, oh, she says that all the time, or, he's just looking for attention, maybe the time that they go out and actually make, a more lethal attempt because they feel like nobody cares. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. We know that this is false. Most people will tell you when you ask. And as I said before, it's often a relief for them to, finally talk about it. And it's because ambivalence is characteristic in 95% of people who are suicidal. The wish to die that comes with depression is actually fighting against the human species instinct to live. It's actually very hard to overcome that instinct to survive and make a suicide attempt. And it's why we see about 80% of people give hints and warnings to friends or family, either over the internet or by statements they make or things that they write. And we know people want to be asked because they tell us themselves. So we work a lot, very closely with a man named Kevin Hines. If you've never heard of Kevin, you should Google him and hear his story. But Kevin is a survivor of jumping off the Golden Gate Bridge. It's lethal 95% of the time. When he made his attempt, he was 19 years old. He had a psychotic depression. Voices were telling him that he had to die. But he made a pact with himself that if just one person asks me why I'm feeling so bad, I'm going to tell them. And so he gets on the bus to go to a bridge, and people on the bus are changing their seats so they don't have to sit next to this weird crying kid. He gets to the bridge, and the bus driver shoos him off and says, come on, I got stops to make, you got to go. He walks up and down the bridge a couple times and nobody says anything. And finally, he makes eye contact with a woman and she's coming towards him. And he thinks, this is it, I'm going to get some help. But when she gets to him, she says, will you take my picture? And he takes her picture 4 or 5 times, decides that nobody, gives her back her camera, decides nobody cares, and then he jumps. And what he says now is he instantly realized as soon as his hands left the railing that everything in his life he thought was unfixable was fixable except for what he had just done. And he says, he goes on to say that most people considering suicide want somebody to save them. And what we really need is a culture where no one's afraid to ask these kinds of things. Then if you stop someone from killing themselves one way, they'll just probably find another. This is the argument for means safety. Means safety is actually the most evidence-supported suicide prevention measure that we have. And what means safety is, or means restriction, is when you put a little bit of extra time in the way of someone who's thinking about suicide and them having the method in their hands. And when you can make it take just a little bit longer, you give that ambivalence time to work. And very often people change their minds. And we have lots of historic examples of this, going all the way back to the 1950s in the United Kingdom. They used to use a very toxic coal gas in their stoves. It had high carbon monoxide content, and people were killing themselves by asphyxiating themselves with their cooking gas. It's where the expression, put your head in the oven, comes from for suicide. And so in the late 50s, they started replacing it, and they cut their carbon monoxide poisonings by a third without seeing much of an increase in the other methods. So their overall rates came down. Then as recently as 1998 in England, they were having problems with Tylenol overdosing. And so they introduced a law where Tylenol has to be sold in blister packaging, where they punch the pills out one at a time. And when it takes just a couple extra minutes to get a lethal handful of Tylenol, they've been able to reduce their Tylenol overdoses by 44% over the next decade. Right? In our country, we buy Tylenol in bottles of 500 at the big box stores. That's what I have in my cabinet in my bathroom here at home. We don't have the same efforts in our country at making it a little bit more difficult for people to get lethal means like medications, firearms, things like that. And lots of examples about how making it a little bit harder to get a gun saves lives. In New Zealand in 1992, they passed a stricter gun licensing law and required locked storage, and they reduced youth suicide by guns by 66%. 85% of youth who use a gun in a suicide use a gun that's already in their family home. And in Israel, in the military, as recently as 2006, they were noticing that they were having their soldiers die by suicide when they were off duty at home. And so they passed a rule where they can't take their guns when they go home now. They have to leave the guns on base. And when they did that, and they don't have easy access to something that's that lethal, when they're struggling with their marriages and their kids and their financial situations, they were able to reduce their military suicides by 40%. Again, because when you're impulsively looking for something to kill yourself with and you don't find a gun, it is much more likely that the ambivalence will take over and you'll change your mind. So we're putting our questions into all the places where people get lethal means. You know, gun shops can put up posters or have our cards on their gun shop counters, and gun shop owners incidentally tell us that they're happy to do that because they don't want to sell a gun to someone and then read in the next day's paper that they killed themselves with it. There's a tremendous amount of guilt for gun shop owners when that happens. We train subway platform workers in New York and Los Angeles, and we're starting to train pharmacy students. Our hope is that someday every pharmacist in, you know, CVS will be able to ask these questions when they're, you know, seeing someone that they know that doesn't quite look, you know, so well. And what this is a move towards a public health approach to treating suicide risk. It used to be we used a very medical model where we targeted our screening at people who had certain risk factors. We trained mental health professionals how to treat depression and suicide. But the problem is that, again, the majority of people who need treatment for depression and anxiety and PTSD who are at risk for suicide aren't going to treatment. And so we don't find them there. We're waiting till it's too late. And so we know now we need to take a more public health approach. And that means universal screening of everybody, targeting a whole community. So if it's a school, you know, we would love to see universal screening of all the students, the same way they get their vision checked every year or they get their scoliosis testing. And so if we're going into a community to train, we want them to bring all of their school staff, their community mental health and physical health providers, their religious leaders, youth pastors, their first responders, any parents that might want to know, and really cast a wide net. And we actually got this idea from the US Marines. They were the first branch of the military that came to us to ask us for training. When they came to us, though, they didn't ask us to work with their behavioral health staff. They asked us if we would come in and we would train their clergy and their financial aid counselors and their lawyers, because the number one precipitating event before a Marine suicide was having a legal problem. So they were arrested for a DUI or a domestic violence charge, and they were ending their lives by suicide because of the impact that was going to have on their military career. So now in the Marines, every time a lawyer meets with a Marine, the lawyer screens with the short Columbia screener and then escorts them to behavioral health if they score with a high risk answer. And so we believe everyone everywhere can ask these questions. You know, whether you're working as a janitor or a bus driver in a school, or in the community in a Boys and Girls Club, whether you're a bartender or a personal trainer, all those folks can screen. And we need them to, because we need to find people who are suffering in silence in the communities where they're living. And it's why we're now sending out these ACE cards to anybody who wants them. What they are is they're the short Columbia screener on the back, and on the front we modify them for different audiences. So we have one that says ask your spouse, one that says ask your friends, ask your kids, ask your students, ask your athletes, ask your coworkers, ask your patients, your clients. We can make them for just about anybody. And a lot of them you can download right off our website. You can change the photos, or we can change them for you to match a population that you want to address. You can add your logo or your local hotline number and give them out in your communities as widely as possible. And that's what the Air Force has done. Not only did they train and give these to their, behavioral health staff and primary care and their first responders and their support workers, but they gave one of these cards to every airman in the Air Force and one for each of their spouses, so that they can monitor on a peer-to-peer basis and they can monitor their loved ones. So I want to show you a demonstration video that was made by the Air Force chaplains for their internal training. It gives you a good sense of hearing the screener done on a sort of peer-to-peer way. I apologize ahead of time for how quickly they're going to address death and suicide. If you, when you're doing it in real life, you probably would go a little slower and build up to it. But that we didn't want the video to go on too long, so they get right into it.
Come on.
Airman Powell, hey, how's it going? You look frustrated.
Yeah, I'm just trying to come back from leave and let's work.
How did it go? I knew you were looking forward to that leave with your family. How'd that go?
Yeah, I was. Wish I was still on leave, just I had more time, but
You're pretty frustrated, huh?
It was, I'm separating soon, and just being back home and just made things more difficult, and I don't know, it's whatever.
Yeah. You don't really look yourself, Maybe, you mind if I ask you a few questions?
Yeah, that's fine.
Do you wish that you were dead, or that you could go to sleep and just not wake up?
Going to sleep, that sounds pretty good.
So, have you actually had any thoughts of killing yourself?
Yeah, I have.
Well, thanks for being honest with me about it. So have you been thinking about how you might do this?
Oh, I have this gun at home, so,
Yeah. Have you had some intention to act on these thoughts?
I don't know, I clean it and I'm sitting there with it for a while and just, I don't know, things creep into my head and I don't know.
Have you started to work out or worked out the details of how to kill yourself?
Other than sitting there, holding it, and maybe using it, I don't know, it would be so easy.
Right. And thanks for being honest with me. Do you intend to carry out this plan?
No, I think about it sometimes, but...
So have you done anything, started to do anything, or prepared to do anything to end your life?
No, not yet.
Well, thanks again for being honest with me. I know you're having a tough time right now. I can tell that. And I'm concerned about you. I think we should go talk with somebody, make sure that you're squared away. How does that sound?
Yeah, I guess so.
Okay.
So we know that we need to screen. We know that we have lots of places where screening would be effective. We know that nearly 50% of people who die from suicide see their primary care in the month before they die, and that 2 out of 3 adolescents who have attempted suicide come into the ER for a non-psychiatric problem. We aren't doing all that we can to screen for suicide and find these folks. We know that screening programs work. A meta-analysis by John Mann showed that screening resulted in lower suicide rates in adults. Another study showed it helps with detection of depression in the elder primary care settings. A high school screening program did a better job identifying students with mental health issues than relying on the school clinical professionals to go out and find them on their own. And this college screening program, where they screened all incoming freshmen anonymously, so they just sent them the screener, didn't ask for any feedback, their names. It actually not only reduced suicides over the 4 years after doing that, but it actually also increased the numbers of walk-ins to their mental health clinic during the year. So more people felt connected and that it was okay to talk about this just by getting sent a copy of the Columbia. So we know suicide's preventable. Our efforts, of course, have to identify those at highest risk. And the Columbia tool was developed in a National Institute of Mental Health study, looking for something to assess adolescents who were coming out of the ER to see what was going on, whether getting better or getting worse. And it was done at Columbia and NYU and University of Pennsylvania with Aaron Beck's group there. Since its development, it's been used tens of millions of times. It's available in over 140 languages now. It takes a very short time to do, just a minute for the very short 6-question screener and just a few minutes for the longer full version. It's considered the most evidence-supported suicide risk assessment that is available. It's good for all ages. The regular scale is good for ages 6 on up, and it can be used with all different special populations. The definitions that the Columbia team developed are now the definitions that the CDC and the Department of Defense are using. They have a booklet for suicide researchers that links to our website, but it also there has a list of words we should stop using, the unacceptable terms. Things like completed suicide and successful suicide, right? You complete a project where you're successful at your job, and we want to take those positive words away from an act like suicide. And we also hear now from survivors that they'd like us not to say committed suicide because it makes them feel like their loved ones committed a crime. And so now the only way we think we should be talking about suicide is to say someone died from suicide or ended their life by suicide, to be just very, very clear and succinct. Now, the National Action Alliance for Zero Suicide has a toolkit for healthcare environments that includes the CSSRS for assessment and a safety plan for all individuals who are at risk. The safety plan that they recommend and we recommend is one written by Barbara Stanley and Greg Brown, both also authors on the Columbia tool. Barbara Stanley is here at Columbia, Greg Brown is at University of Pennsylvania. But the poster agency, the model agency for this Zero Suicide program is Centerstone, which is one of the largest outpatient providers of behavioral health care in the country. What they do is they screen every single client every time they see them. So if a patient comes in and has medication management with their psychiatrist for 15 minutes, then they go to a group and then they see their case manager, they'll get screened 3 times in a day. And that's because it takes just 10 seconds, 15 seconds to ask the questions. And most of the time the answer is no. And you go on. But you will find those folks who have developed these thoughts and feelings and behaviors. Then if they score high, they enter into their suicide safe pathway of care, where their name changes color on their electronic medical records so that every provider knows that this person is at risk. They get weekly appointments, they get education about means restriction, and they get a safety plan. And if they don't show up for a therapy appointment, the clinician attempts to reach out to them by phone. And if they can't get them, then they have social workers who do continuous phone outreach and reassessment over the phone until they can get them to come back in. And they've reported that in the first 20 months of doing this zero suicide model, they reduced their suicides of their outpatients by 65%. So these Columbia tools, it's a semi-structured interview, which means that we provide probe questions. You can ask them exactly the way they're written in bold on the forms. but it's not required that you ask any or all of them, as long as in your conversation with someone, you've collected enough information that you can go back and identify that they had this level of ideation and they had any of these behaviors that we're going to go over. Most of the time, you'll rely on the individual who you're interested in telling you the information, but if they can't or they won't, then you can use other sources of information, like a family member or a friend, a past medical record. This can be very helpful for children and adolescents, you know, who may not give the same information their parents or other caregivers give you. It can be very helpful for someone who may be unconscious or with dementia. You can ask their caregivers what's been going on. So either the short or the longer full version are both an assessment of suicidal thoughts or ideation and behaviors. Both of them start with ideation, and they start with the same first 5 questions that you heard in the video. Those questions increase in severity from question 1, which is a wish to die, question 5, which is thoughts about killing yourself with a plan and intent to act on that plan. Then the full version has 5 more questions about intensity of ideation. Those are 5 questions about the time that they had the highest rating on that first 5 questions. Then you move on to behaviors. And for behaviors, finally, we're assessing all relevant behaviors that increase risk for suicide. It used to be we just asked about past suicide attempts. And when that was the only behavior we were interested in, we missed the people who practiced how to tie a noose or looked up ways online to kill themselves or put a gun to their head and then changed their mind and put the gun down. Things that we know now have equal risk to past attempts. That's on both the short and the longer version. And then on the longer version, the final section is on lethality of any actual suicide attempts. So if they made an attempt, how much medical damage happened? How lethal was it? So again, for ideation, the full scale is 1 page, 10 questions. They start with the same first 5 questions as the shorter screener. Have you wished you were dead or wished you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? If question 2 is no, you can move on, skip 3, 4, and 5, and move on to question 6 or the next section. But if question 2 is yes, then you ask, have you been thinking about how you might do this? Have you had these thoughts with some intention to act on them? And have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out your plan? You can't have a method or intent to act or a plan if you've never had a thought about it before, which is why, to go more quickly, you can skip 3, 4, and 5 if they haven't had any thoughts. And we know that as you increase from the wish to die up to having plan and intent, you increase your odds ratio of making a suicide attempt from about 6 times on up to about 26 times at risk for all patients. So I'm going to show you another demonstration that we made of somebody asking the ideation questions. And you'll see another example. I think the more times you see this, the more comfortable you become with it.
So tell me, what brings you to see me today?
I've been feeling kind of crummy, problems with my family, and things at work aren't going so well.
Have you been feeling depressed?
Well, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
See how asking the wrong question can shut down the conversation? Watch now how asking the right questions using the prompts on the CSSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So in the example you just saw, the answer circled would be a 4, intent only, not intent and a specific plan. In this next example, a 5 would be indicated. Watch.
Sometimes I think that I'll jump in front of a train or a bus.
Well, have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
Yes. I got a subway schedule and I saw that there's a station that between 7 and 8 o'clock at night, there aren't many people there, and that's what I was going to do.
Well, do you intend to carry out this plan now?
I worry that I might.
Okay. Thank you for being so honest with me. We're going to get you some help right now.
Thank you.
You see, it would be a 5 because he had intent and a specific plan with the intent to act on it, all the details worked out, etc.
So if you're doing the full scale, you have these 5 follow-up questions on the time that they scored the highest on the previous section. And these are questions about the frequency of the thoughts, the duration of the thoughts, how controllable are the thoughts, do they have deterrence to acting on the thoughts, and what's the reason behind their thoughts? Is it to stop the pain that they're feeling or to make something else happen? And so logically, risk is greater when thoughts happen more frequently, when they last longer, when they are impossible to control, when they have no deterrence to acting on them, and when it's to stop pain. And so you can add up the multiple choice answers that you select here, and it will give you a score for the section on roughly 2 to 25. We don't have clinical cutoffs for this section as far as risk is concerned, which is why it's not part of the short screener. But it can give you some information that can help your clinical judgment. If you're looking to see if someone's getting better, the score might come down. It's obvious that a score of 20 is more worrisome than a score of 5, for example. And if you're working with adolescents, the second question is a very important one. Cheryl King showed it was the most predictive question for adolescents. And it's how long did the thoughts last? And if they lasted all day long, they are thinking about it over and over and over again, then you would worry the most about that adolescent. So then we move on to suicidal behavior. Behavior looks at 4 specific behaviors on the full version. And the first behavior and the first definition we provide is a suicide attempt. And a suicide attempt is a self-injurious act undertaken with at least some intent to die as a result of the act. And there are 3 important components. The first is that it says self-injurious act. It doesn't say self-injury. There doesn't have to be any physical injury for it to be a suicide attempt, just the potential for that injury. So if somebody does pull the trigger on a gun and the gun fails to fire, even though there was no physical damage, it's a suicide attempt. Second part is that any non-zero intent to die, but it does not have to be 100%. Often people have mixed motives when they make suicide attempts. Some part of them might want to get revenge, to get noticed, to, be famous. But as long as a little part of them wants to die when they do it, then it is a suicide attempt. And very often if you ask someone, did any part of you want to die when, you cut yourself or took that overdose? A lot of times you'll find out the answer is yes. And then as a result of the act, meaning that the intent to die and the behavior have to be linked. They have to be doing that behavior in order to make themselves dead. Now, you can infer suicidal intent in a couple different circumstances. The first is that if someone denies that they were trying to kill themselves, but they thought what they did could kill them, and they did it anyway, you can infer it was an attempt. Or in what we call clinically impressive circumstances. That's where what somebody does is so obviously a suicide attempt that you wouldn't mistake it for anybody else, for anything else. Any average person would call it an attempt. So the attempt begins with the first pill swallowed, the first scratch you make with a knife. You can ask questions like, have you made an attempt or done anything to harm yourself or done anything dangerous where you could have died? And the reason why we ask a lot of questions and have a very strict definition is we're trying to oppose this to non-suicidal self-injurious behavior. That's when someone engages in suicidal behavior and it's 100% for a reason other than ending their life. It's usually to affect one of two things. It's usually to affect how someone feels on the inside. So they're feeling pain and hurt, and physically hurting themselves helps to release that pain, or they're feeling numb inside and the adrenaline from hurting yourself makes them feel alive and present. Or it's to affect external circumstances. That's someone who wants to get sympathy from the world, so they say that they're suicidal. Or someone who's homeless and wants to get hospitalized because it's the middle of winter and they don't have a place to stay. Now, the other behaviors are what we call an interrupted attempt. That's when someone starts to take steps to end their life, but someone or something stops them. That's someone who has a bottle of pills or a gun and someone grabs it away, or they're on the ledge ready to jump and someone pulls them back. Someone recently told me about an interrupted attempt where somebody's dog, came into the room and started nudging them and they changed their mind. Then we have aborted or self-interrupted attempts. That's when you change your mind. You start to take the steps, but before you do anything that can hurt you, you stop. So that's someone who's planning to drive their car off of the road and halfway there, they turn around and come home. Someone who picks up a gun but puts it back down. And the final behavior are preparatory behaviors. That's any behavior with suicidal intent. So doing things like collecting the means that you're going to use, giving away your valuables because you won't need them, writing a suicide note, looking up ways online to kill yourself. And, we think that by asking about all types of ideations and behaviors, maybe we can find kids like Dylan Klebold, one of the Columbine shooters. He actually mentioned suicide more than 5 times in his journals. He wrote things like, I don't fit in here, and thinking about suicide gives me hope. We believe that, we may actually take some of these kids who are suffering, who have potential for violence, and get them the help that they need. Now, it turns out that all 4 of these behaviors have an odds ratio of roughly 5 times for someone making an attempt in the next week. And these other 3 behaviors we didn't choose to ask about are actually much more common than actual behaviors, than actual attempts. When this look at 30,000 admissions of the Columbia was done, they found that 87% of them were those other 3 things, interrupted, aborted, or preparatory behaviors, and only 13% were actual attempts. Then the final section on the full version is lethality. And that's based on the Beck medical lethality scale. It's what kinds of medical damage happened in an attempt. So if it was a cut, did it have to be bandaged? Did you lose blood? And did you have to go to the hospital for stitches or lose consciousness? And that's just rated by the clinician or the rater from 0 to 5. 0 being no physical damage or very minor physical damage, and 5 being that it resulted in their death. And then the final question is potential lethality. That's for any actual attempts where there was 0 medical damage. You mark what is likely to happen if they tried the same method next time. And that's there because they wanted a quick place where they could see that if somebody did pull the trigger on a gun and the gun fails to fire, or they lay on train tracks and then get off of them before the train comes, they wanted a place where you could very quickly note that that was a very lethal attempt, even though it was 0 damage the first time. And if they tried that again, it probably will not turn out that way. So let me show you a video of someone asking these 4 separate behaviors.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? Have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No,
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? But someone or something stopped you before you actually did anything?
a friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No.
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
No. Not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
Okay, so she had some significant issues. She had an actual attempt. She had an interrupted attempt. She had to preparatory behaviors, right? So when you're doing this on the full version, you'll select all the different behaviors that apply, but only if they're discrete behaviors, part of an individual episode. If, for example, in that video, the pills she kept under her pillow are the same ones that her friend took away from her, you wouldn't count that as two separate things. You would count that just as an interrupted attempt. It's also important to ask about behavior, even if all the ideation questions are answered no, because we have seen an occasional individual who will say they never had a thought before about suicide, but they made an attempt because it was so impulsive. And it's also important to listen to what the person believes is going to happen when they do what they do, and not base whether it was an attempt on what we think. This is important, especially for very young kids who sometimes do some things that we know won't kill them, but they say they're trying to kill themselves, like putting their head into a pillowcase. Or it's also very important for folks who might be psychotic and might come up with some strange ways to kill themselves. So if you're doing the short screener, all 4 behaviors are combined into question number 6, which says, have you ever done anything, started to do anything, or prepared to do anything to end your life? Now, the time frames about what we ask about are important. So the first initial intake scale that we have is what we consider the lifetime recent scale, which has 2 scoring columns, one for lifetime, which is the time they felt the most suicidal per ideation, and for the recent time period, which tells us if they need to go to the ER today. The recent time frame is the past 30 days for ideation and the past 90 days for behavior. The authors determined that after those time windows, the odds of someone making a suicide attempt in the near future drop dramatically by more than 50%. And we know that we need to monitor. So the same way that Centerstone asks every time they see someone, they use the short screener with a since last asked time frame. So they say, for example, since you were last asked, or since I last saw you, have you had any thoughts about suicide, or have you done any of those behaviors? That's all you have to ask for follow-up. So doing it every time you see somebody is pretty much a no-brainer. It's just like checking in. You don't want the time that you don't ask, of course, to be the time that you needed to. And so what do we worry about? High-risk answers are a yes to question 4, 5, or 6 on the screener, which is having intent to act on your thoughts, or a plan with intent, or any one of those 4 behaviors within the past 3 months. Those indicate the most extreme next steps, keeping someone safe until a mental health person can evaluate them for possible hospitalization, because it's high risk that they'll make an attempt. If you're doing the full version, it's the same thing. It's high risk if they have a yes to question 4 or 5 in the recent time frame of 1 month, or a yes to any of the behaviors in the time frame of 3 months. Now, our toolbox is extremely flexible. We have lots of versions with different next steps for different settings, but no matter who's using it, inpatient, outpatient, primary care, the Air Force, your friend, it's always the same high-risk answers, always 4, 5, or 6, and you need to escort someone to safety. Let me show you one of the most beneficial aspects of the scale, which is how we can use it to determine someone doesn't have to go to the ER when they're not at high risk.
I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to CSSRS, and I could use a few quick questions to help me decide what level of care she needed.
Hi.
Are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that. All right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Okay, so he asked her questions 1 and 2. She said yes to question 1, but no to question 2. And so he asked her question 6. She said, yes, I had a behavior, but it was a long time ago, right? So this is somebody who is at moderate risk because of an old behavior. This is somebody who should be in counseling, perhaps. So he could say to her, do you have a therapist you see? When's your next appointment? Can we get you an emergency appointment? He could say to her, I have a list of local clinics that we can look at and find one maybe to call and get you an appointment. He would give her a crisis number, and he could ask her if she had anybody, family or friend, that she could spend the day with so she doesn't have to be alone. What he doesn't have to do is take her to the ER, where he has to come off the street and not do his job, and she will have to sit for 8 hours in the ER waiting to be evaluated, when we know that being evaluated in the emergency room when you don't need it, you don't end up hospitalized, and they send you home, is actually detrimental. It actually results in people not following up with care. And we want to save those ER referrals for when we know that it's absolutely necessary. And so a lot of places are using the screener for just that purpose, for crisis assessment. The state of Tennessee, for example, uses the screener alongside with a checklist that we have of risk and protective factors that the authors developed out of a request for some way to note what the sort of lifetime worrisome issues might be. Risk factors are things that, of course, increase someone's risk for suicidal behaviors. Protective factors prevent, reduce the likelihood. The risk factors can be biological or psychological, like having a chronic health issue, having command hallucinations, being aggressive or homicidal, or a violence perpetrator, being a survivor of sexual or physical abuse, having a family history of suicide, having a psychiatric or substance abuse diagnosis, those kinds of things. And they can be social or environmental. So things like having a recent loss of a job, of your home, of a partner, pending incarceration or about to be evicted, feeling hopeless, being exposed to the suicide of a peer or a public figure, being truant, having easy access to a method. And it includes protective factors like having the ability to identify reasons to live, feeling responsible to your family, feeling like you have a supportive social network or supportive family, having a fear of death or dying, believing in high spirituality, and that suicide's immoral, being engaged in schoolwork or sports. And so we've also taken these risk and protective factors and the Columbia questions and cut and pasted them into the format that SAMHSA recommends assessments be done called the SAFE-T. And so that's also available to use. Again, it's just the Columbia plus risk and protective factors, and the risk stratification of high, moderate, or low based on the Columbia answers. You can add questions to the Columbia if you've got a certain population you're working with and you want to ask about particular risk factors maybe for that population. The military created one where they ask about legal troubles, financial troubles, marital troubles, how many deployments they might have had, and did they see combat, that kind of thing. We also have a very young child or cognitively impaired version of the scale, which takes the same, assesses the same items, but gives you other ways to ask them for a 4 to 6 year old. Things like, it says things like, make yourself not alive anymore instead of kill yourself. And so if you're working with very, very young kids or cognitively impaired folks who operate on a 4 to 6 year old age level, you might want to look at these to get some ideas for how to ask the questions. We have a very flexible and innovative delivery modes. You can put these on posters in your workplace. You can administer them electronically by tablet or phone. We have an app for iPhone and Android. If you go to the app stores and search for Columbia Protocol, you'll find access to our app, which asks the 6-question screener and then spits out a risk level. And it's being used extensively now because of COVID in telehealth. And what we're seeing is that it's really the equivalent to in-person assessment in accuracy, effectiveness, quality of care, and patient satisfaction. And it's having a huge impact on care delivery, service utilization, and liability. Because we're decreasing false positives. This is a study that Cleveland Clinic did looking at the PHQ-9, which is a depression measure, but has one suicide question, although it's a very poor suicide question. It resulted in 24% positive answers, whereas the CSSRS came up with just 6.2% positive. So doing the Columbia right off the bat is going to, weed out a lot of false positive answers that you might get if you use the PHQ-9. This is what happened at Reading Hospital after they started using the Columbia. All of their psychiatric consults and one-to-ones on their ER service were below levels that they were prior to using the tools. Centerstone reported they reduced their recidivism to the emergency department of their outpatients by 33%, from 40% to 7%. And people worry that if we start universally screening people, are we going to have just a lot of people to worry about and a lot more work to do? And the answer is that we're seeing that that's not the case. Parkland Hospital in Dallas, Texas was the first hospital to do universal screening. They reported after the first 100,000 patients that they had 1.8% with positive answers, and they have hired a dozen social workers to follow up with all those folks. In the Connecticut National Guard, they started using it as part of their periodic health assessment. After 38,000 screenings, they identified 17 soldiers that needed assistance. And this is a study that was done at the VA hospital in Detroit, Michigan, where they screened 3,000 vets who were seeing a psychiatrist who had a mental health problem. And when they did that, they found that after those 3,000 were assessed, they had 14 that they had to follow up with, so half of 1%. And of those 14, 5 had to be hospitalized. So again, they found 5 patients they might not have found otherwise, didn't do a lot of extra work, and screened out, false positives. And this can actually protect you from liability. People also worry, if I start screening and using this tool, aren't I going to open myself up to a lawsuit if something bad happens, if I lose a client? And what medical malpractice attorneys who were interviewed for an article on the Columbia said was that if this is the gold standard, which we believe it is, that provides you with protection. You know, where people get sued is where they asked something that has no science behind it, or they didn't do anything at all. Someone in a training recently said, you don't get sued for bad outcomes, you get sued for negligence. And so doing this, documenting your answer, taking the proper next steps is the most, you know, scientifically based, evidence-based, protective measure that you can take. And so we believe that just getting one of these cards with the questions on it, it actually is an intervention in and of itself, because we know that using a common language and connecting around issues of mental health and suicide can reduce the loneliness that exists in at-risk individuals. That loneliness, incidentally, is roughly equal to 15 cigarettes a day in chronic health problems. It's more lethal than heart disease and obesity. And it normalizes these tough conversations and reduces stigma, which we know is what's going to, in the end, encourage people to come forward when they're in crisis. So that's the information I wanted to share about the Columbia. If you have any questions or need any materials that you can't find on our website, which is cssrs.columbia.edu, you can email us using Dr. Posner's email address, which is kelly.posner@nyspi.columbia.edu. There's also a contact us page on our website that you could use. And we're always happy to hear from you and to provide you with whatever it is that you need.